All right, everybody. Again, great to see you. So today we're going to go through some renal clearance studies to kind of follow up some of our discussions we've had about sodium. Um, I think urine clearance studies are confusing and something that we rarely ever do. And when we do it, we might not do it correctly as well too. So I wanted to have a chance to work through some of it because I think as nephrologists, we are the only ones who can understand this. Everyone else will give up and they won't try, they won't be able to. So we want to be comfortable with these topics and and use them and to apply these things, and hopefully these two patients, which are real life patients, these are not things I made up, we will use some of these concepts to help actually understand and manage our patients a bit better. So why don't we start? I was not planning today to go through the three papers in detail because I want to use them and actually go through the cases. But let's open it up. Were there any questions about the papers themselves?
Hi everyone. I I read the three of them. I really appreciated some of the aspects of like with the case explanations, especially from one of them. He had like six different cases, which was kind of like easier to understand the applicability of using osmolarity and tonicity to understand what's going on. But although it's really tricky, and I kind of like miss because I got curious and then I went through some other references more specific to the veterinary medicine. So I was like kind of, oh, do we have like the same like tonicity or osmolarity compared to dogs and cats and that kind of stuff? So I think it's a really interesting and also not it's a challenging topic, but it's also like you have to research like what do we have for small animals as well. So it's kind of like very it's totally new for me, but I really like though. It's challenging, but it's really nice.
Yeah, I agree. We don't have reference ranges for any of this. So most of these studies are based off of 24-hour urine collections, which we don't do routinely or
Hmm.
ever. I don't think I've ever done a 24-hour urine collection. I haven't. I can say that definitively. I've never done a 24-hour urine collection. We don't have reference ranges. We have some studies that have looked at 24-hour urine in dogs, less so in cats, but there are some basic concepts that we just don't know. So
Hmm.
something is as simple as, well, what's a normal 24-hour urine osmolality? What's the normal amount of solutes that are excreted in 24 hours from a healthy dog or healthy cat? We don't know that. I've done a
Yeah.
deep dive. I asked the listserv to see if anybody had that information, and that is unpublished that I'm aware of. I cannot find any reference to the amount of solutes a normal dog eating a maintenance diet is going to excrete per day. So we are left with taking reference ranges or normals from
Hmm.
people and applying it, which is not perfect, but I think the concepts are going to work, and I think the concepts are going to still be translatable from one to the
Can I ask you just one like quick question regarding the urine osmolarity? So I was like doing some like pretty basic research, and I went through a Cornell website to figure something about like more related to canine and feline. How could you find the urinary osmolarity? It's so hard to say osmolarity, and and then I found out that there's like a two line of orientation down there saying that for you to find it, you have to multiply the last two numbers from the USG times 36, and then you have the urinary osmolarity of that urine. However, they explain that the USG may vary according to the day or according to the time. So that's why it's tricky for you to define the osmolarity of like a 24-hour, because we don't pool the urine as you just mentioned, like for a 24-hour like urine pool. But I don't know if you use that reference as well, or if you have like another reference that you could share with us.
Yeah, Andre, you perfectly segued into the very first slide that I put together for today's presentation. So urine osmolality and specific gravity are correlated. Remember, there's a difference. So osmolality is purely the number of solutes in urine. The specific gravity is dependent both upon the number of solutes and the molecular weight of the solutes. So if there are larger molecules such as glucose and protein, that could cause your urine specific gravity to increase more than what the osmolality would. And there are some old formulas to correct for it. Interestingly, there have been some newer studies that have looked at the impact of hematuria and glucoseuria and proteinuria on specific gravity and found it to be fairly minimal, but it's still some effect. So there are formulas. This is from a paper from 2003, which gave a regression line. And so they gave a slightly different formula, which is essentially the same thing because they multiply essentially the last two digits by 37,000 to get the USG here. And it works okay, but it's not perfect. And if you look at these outliers that you have. You have some that are much lower, that are much higher in terms of the osmolality versus the USG. Most patients fit along that line, but it's not perfect. So I think specific gravity is a reasonable estimate for it when we don't need to know osmolality. But anytime that we're making evaluations of dysnatremias or PUPD, we need to know the osmolality. And Andre, you're right, it could change, just like specific gravity can change throughout the day. The morning USG and osmolality might not be the same as midday or in the evening, but that's where we might think about doing a pooled sample, just like we might do a pooled UPC. We have the owners collect a urine sample in the morning, in the middle of the day, in the evening, pull a mil from each, submit that as a single sample to get the pooled osmolality. That will help minimize some of that variability. And that's a reasonable thing to do. Ultimately, looking at a 24-hour excretion would be the gold standard. But again, we don't have reference ranges. We don't have normal. So we can do it, but we have to interpret it with our own expertise. We can't just say, aha, this dog has a high 24-hour urine sodium, and therefore we can make some claims based upon it. That would be terrific, but we don't have those numbers. And I think as we might gain the ability to do urine chemistries easier, we might get more information. I know IDEX is kind of working behind the scenes to see if they can have their SediVue urine analysis machines be able to do some basic chemistry measurements on it as well. So there might be more options to do this in-house. But for me, I send my urine to Cornell to get osmolality and the chemistry and everything performed because they are pretty cheap and they're very fast. Even sending it out to IDEX right now, it can take a week and it's expensive. So yeah, so USG does correlate, but not perfectly to osmolality. If you want to know what osmolality is, you have to measure it. One of the papers, I think maybe the Bud Rose paper, talked about the tight regulation of ADH and osmolality in people. And I think they quoted a number that ADH starts to become increased when the osmolality reaches like 285, a pretty tight window. So I tried to look at some information in dogs, and this is a study where they infused hypertonic saline to dogs via a jugular catheter and looked at the change in their ADH levels, essentially. And a pretty small change in osmolality, going from 0 uh, to like a minute or so, maybe even 30 seconds. Osmolality probably jumped up about 5 points. We're already seeing ADH that starts to increase, and you can see that it increases parallel to the increase in the plasma osmolality. So although this paper doesn't give an exact number for where ADH is increased in healthy dogs, I think this proves that we have the same scenario, which is exactly what we'd expect, that ADH tightly regulates osmolality. As osmolality goes up, ADH will increase. What this paper also showed, which was interesting, is we talk about the flip side, that if you are in a hypoosmolar state, if you are hyponatremic, if you're hypotonic, that you should have a decreased amount of ADH that's being released. And this paper actually showed that they infused the hypotonic saline, and as the osmolality went down, there was really no change or minimal change in ADH. So it's almost like you have this steep curve that goes up when osmolality increases, and then it kind of flattens out when ADH decreases. So you might expect that curve should just keep going down as your osmolality goes down, but there certainly seems like there's the set point, which is the pivot point, and then it operates a little bit differently. So I don't think this is sufficient to say that dogs do not have reduced ADH in hypotonicity. I don't think that is what this is saying. Certainly some did, but it's probably not quite as reliable. Now, this is a study of healthy beagles that have sterile water or D5W put in through a jugular vein. Probably not what happens in perfect real life scenarios, but it's pretty controlled situation. So from what we know in dogs, I think the exact claims that are made in people in terms of regulation of osmolality and ADH and the expected changes in water elimination should occur in our patients. And I think that's a good background to say, okay, well, let's presume that our patients are going to act the same, and let's use some of these numbers to evaluate how we can use them in our evaluation of looking at dysnatremia and PUPD in our patients. So should we get into case number 1? Does that work? Any other questions before we dive in?
No,
Okay,
just
so
tricky.
let's talk about this. Andre, do you have a question? Sorry, I didn't mean to talk over you.
No, I was just thinking because I took some notes from the paper from '94, and once you were sharing the dogs data according to the ADH secretion, and I was like I was when I did some like basic studies regarding GFR, we also are so acknowledge that aldosterone has like a major role in the tonicity and osmolarity as well, like as retention of uh, sodium, right, specifically. So they they don't mention like the aldo axis at all. So I kind of like I I don't know if aldo has like no participation at all regarding the tonicity and the both like statements as hypotonicity or hypertonicity, or if just the paper did not wanted to mention that, just to not like becoming like a larger paper as it was.
Yeah,
So do you have any thoughts like
yeah,
regarding like the aldo axis?
absolutely. I think that's um, an important area that gets overlapped. So our
Mm-hmm.
RAS system is there to manage volume, and it does so without actually having an obvious influence in sodium. So aldo is going to cause sodium to be reabsorbed, but water follows in an isotonic fashion. So when we have Ang2, that increases proximal tubular sodium reabsorption, and aldo, which increases distal reabsorption of sodium, water follows. So we're not adding salt without water. We're adding salt
Mhm.
with water. So volume
Mhm.
increases, but tonicity does not change. So in terms of changes to our tonicity, to changes to the osmolality, that will be solely affected by ADH and thirst. That's it. The RAS system is not involved with regulating osmolality. Now, many of the conditions that could cause a patient to have an abnormal osmolality, think of a diabetes insipidus patient who has a free water loss who becomes dehydrated. They are hypertonic, they're hyperosmolar, and they're volume depleted. So that patient will have ADH that's released because of both, because of the hypertonicity and because of the volume. But the volume will also stimulate the RAS. So that patient will have salt and water being reabsorbed from Ang2 and aldo, but that's isotonic, so that's not going to change the osmolality. It's going to have ADH that's going to pull water by itself, which will bring the osmolality down, and then ultimately needs to drink to replace the volume deficit. So when we look at sodium disorders, you can essentially get rid of the RAS axis in terms of something that we need to manage, because your RAS axis will not be involved with establishing a sustained dysnatremia. It has to be ADH, it has to be thirst. So it is not going to play a major role. So it's huge in terms of our volume, but it's not there to play a role in our regulation of osmolality.
Thank you, JD.
Cool. But I think it's hard because those things are there at the same time, so it's hard to separate. All right, so we're going to go through this case. This is a pretty bonkers one that we had, that we still have. So long story short, Coco is still with us and doing extremely well. 9-month-old, and maybe she was even a bit younger than that. Female spayed Pomeranian mix. I think she was maybe 1.3 kilos, something like that. Had acute kidney injury of not very well known and established reasons for the AKI, and developed hyponatremia along with it. I provided you folks with a single time point's worth of blood work and the urine tests that were obtained at the same time. If you're not familiar with it, this is a fishbone diagram, which is commonly used in human hospitals to show the results of a basic metabolic panel. It is a very fast and easy way to write results of electrolytes in a blood gas, because you have your sodium and your potassium, so those are your cations, your chloride, your bicarb, those are your anions. So taking the first column and the second column, there's your anion gap. You have your kidney values, and then depending on your panel, you might write the phosphorus or maybe the glucose or something in between. So those fish bones are great. I write them all the time when I'm just taking notes on patients, and that's how I'm going to present the numbers, so I don't have to present a paragraph over and over again. But if you don't remember what they are, I'll remind you. So let's start taking a look at Coco. So she has a plasma osmolality of 250, and she is hyponatremic at 116, pretty darn low. She has a urine osmolality of 579. So if we just start there, this dog is hypotonic. She has a low sodium. She is azotemic, and you can see, I mean, she's a tiny dog, but her creatinine's 0.6, which is obviously disproportionate because she's so young and so small, but her BUN was 267. So she's azotemic, which is going to add some osmoles, but she is hypotonic still. In the face of a hypotonic state, the body, the kidneys, should have essentially no ADH, that they should be dumping as much free water as possible. So remember, as your tubular filtrate goes from the glomerulus and goes through the tubule, throughout the proximal tubule, salt and water is pulled out equal molar. So if you're plasma osmolality is 250. Your glomerular, the urine in Bowman space within the glomerulus has an osmolality of 250. As it goes through the proximal tubule, the osmolality is 250 still. It's not until we get to the loop of Henle. On the way down, water can be pulled out. On the way up, it's impermeable to water, but we have active reabsorption of solutes. So when we get to the distal tubule, it is hypotonic. It's actually hypotonic because we've actively reabsorbed solutes. And now, if we are not removing any free water, because there's no ADH, which should be the appropriate response to this hypotonic state, we're going to dump out that hypotonic fluid with all that free water that's there. So that is the anticipated response. If you gave a patient a liter of D5W and you meant to give them a liter of saline and you made them hypotonic, that's exactly what should occur. So if we just start with the fact that her urine osmolality is more than twice her plasma osmolality, what does that mean to you?
Doesn't seem sustainable to me.
It's not a good idea for sure. How can we get into this state?
I was wondering if there could be inappropriate release of ADH.
Yeah, so in order to have the urine osmolality increase, we have to pull water out. So there has to be ADH released here. And there shouldn't be, right? There should not be ADH in this scenario. If she is volume depleted, then there could be a non-osmotic stimulus for ADH. So remember, you have two stimuli for ADH, tonicity, and that's your paraventricular and supraoptic nuclei of the hypothalamus. Those osmoreceptors shrink and swell with changes in plasma osmolality, which stimulate the release of ADH through the posterior pituitary. That's the first. The second is you have your baroreceptors in your carotid body and other places that sense vessel stretch. And in response to hypovolemia, decreased stretch, you can have a non-osmotic release of ADH. It's why we can see some dogs with like pericardial effusion or ascites have a pseudo-Addisonian electrolyte panel. They're hyponatremic because of that non-osmotic ADH release. So if she was volume depleted, maybe that could be accounting for it. But I think that she was probably okay in terms of her volume. And we'll get to that a little bit more. But I agree, there's probably ADH here that shouldn't be. So let's figure out if that's the case. So we can look at her free water clearance. So her free water clearance, if there is, in this state, she should be dumping out as much free water as possible. She should be getting rid of that free water to increase her plasma osmolality. So let's just go through some of the math. So it's her urine volume times 1 minus the ratio of her urine osmolality to her plasma osmolality. So in both of these cases, definitely in the first one, you don't have a urine volume because this was a spot check. So do we stop here? Do we not have anything? No, we can make some assessments by giving an arbitrary volume. She's making urine. We got a urine sample. There's urine being made. So you can put in any number that you want there. It is really arbitrary. So I'm going to say she made a liter of urine. And even if she didn't, it allows us to conceptually evaluate what happens with every liter of urine that she is in fact making. So just by doing the math, plugging in a liter, her free water clearance tells us that for every 1 liter of urine that she makes, she clears negative 1.3 liters. So essentially, for every liter of urine she makes, she gains 1.3 liters of free water. So if we look at that from the opposite side, the free water reabsorption, and they give these formulas which are essentially the inverse of each other, but we can look at her free water reabsorption. We can do the math in the same way, and it turns out to be the opposite. Her free water reabsorption is exactly the same, but it's positive. So it's 1.3 liters of free water that she is reabsorbing. So why is this? It has to be because, as Mandy suggested, it is the presence of ADH. And then you have to determine, does this patient have a reason for ADH release? Is she hypovolemic? She wasn't. Is she hypertonic? Nope, she's the opposite. Does she have pain, nausea? Is she on a bunch of different medications that can do it? You go through the list, and if you don't find anything on the list, then that's when we usually call these patients an inappropriate release of ADH, or the syndrome of, I spelled that backwards, SIADH, syndrome of inappropriate ADH, or SIAD. There's a couple different acronyms for it, but essentially an inappropriate release of ADH in response to it that's causing the hyponatremia. So if we plot out her urine volume, like what Bud Rose did in that first paper, we can see that if she makes a liter of urine that has an osmolality of 579, and she has this free water clearance of 1.3 liters, she essentially needs to filter 2.3 liters of isoosmotic urine, and then she's reabsorbing this. So every time she urinates, she's actually adding water to herself. And that's the SIADH, which is going to cause her to become hyponatremic. So notice we did this without looking at her urine sodium. We didn't look at her urine sodium at all here. We looked at her osms. But her plasma sodium concentration is going to be reflective upon how much salt, really how much potassium and sodium is present in the urine. So let's look at her electrolyte-free water elimination, because that's actually going to determine what her sodium is doing a bit more specifically. So if we look at those numbers, her electrolyte-free water reabsorption, again, we have volume, which we're just going to arbitrarily put as a liter, but now we start to apply the numbers of her urine sodium and potassium, as well as her plasma sodium. And when we do that, we actually find that her electrolyte-free water reabsorption is negative 0.4 liters. So that means for every liter of urine she's making, she's actually reabsorbing -4. So she's actually excreting 0.4 liters. So if we look at the electrolyte-free water clearance, which again is pretty much the opposite of this formula, we'll find that it's actually going to be positive. So she has a positive electrolyte-free water clearance, and that's more responsible for shifts in sodium than the free water clearance. But she has a negative free water clearance. So if we look at just her electrolyte-free water clearance and we graph that, she made 1 liter of urine, and this is the concentration of the sodium and potassium within it. And of that liter, it means that she excreted 0.4 liters of electrolyte-free urine, and then 0.6 liters of isonatrate. So this is that 0.4 positive electrolyte-free water clearance that we have. So the fact that she's eliminating free water here, this actually suggests that it should increase her plasma sodium concentration. But she's hyponatremic. So remember, I just gave you a snapshot. So do we have a paradox here? She has a negative free water clearance suggesting free water reabsorption and SIADH. But she has a positive electrolyte-free water clearance suggesting that she actually is excreting more free water, which should give her a positive trend in her sodium. Well, let's look at the trend of her electrolytes over the course of her illness. And this is where we pulled her urine chemistry. So she actually had the lowest sodium concentration that I've ever seen in a patient who is still alive. A sodium concentration of 95, double-digit sodium.
That
That
is
is
impressive.
insane. That is insane. I've
That's impressive.
never seen one that low. Have you seen one that low, Sherry?
Have not. You've got me beat on that one.
I've
That
hit the
is impressive.
teens, but I've never hit double digits. And I can't
How
take credit. This is Kaylin's case, but I'm going to take credit.
how was she? I'm just like morbid curiosity now. Like how was she clinically at that level?
Yeah, I don't think she. So the patients I've seen that acutely went down into like the one teens for seizuring, I don't think that she had any seizures. I think she was pretty dull, but I think it was
Yeah.
contributed from her severe AKI as well as her uh, hyponatremia. And Kaylin, if I'm wrong, you can certainly speak up and correct me there. But
I just wonder. I'm just wondering how protective that urea was too, because
yeah,
that's. I mean, like at 95, no one's doing long division. Like
right,
that is a low.
yeah. So
Wow.
we can
Yeah,
see that.
she was like dull, like consistent with like a kind of a severely azotemic patient, but not what you would expect with that degree of hyponatremia. So she was kind of interesting.
So looking at the overall clinical picture, we pulled the urine here on day 8 of her illness. And we can see that things actually were worse and they are improving. So this actually substantiates everything. That even when she came in on day 0, when she was first evaluated in sodium of 115, there's your SI-ADH right there. And despite that, she got worse. And then she's had an improving serum sodium concentration. Why is it improving? Because of her electrolyte-free water clearance. Actually, that 0.4 liters of every liter of urine she's making, she's eliminating 400 mils of free water. That's going to cause her sodium to go gradually up. So it absolutely fits with what we're seeing here. Now, what would have been really interesting and would have shown a different picture is what did her urine look like on day 0? What did her urine look like on day 3? So if we just had today, without knowing the big picture, it was going to be more challenging to interpret it. But luckily we have her electrolytes to plot to see where everything is going. So she was improving and she continued to improve her sodium concentration because of that small but positive electrolyte-free water clearance. So let's take a closer look at her urine osmolality. So her urine osmolality is 579, but her urine sodium and potassium is not really that high. So the urine osmolality, it's pretty much the same formula as plasma osmolality, but we're excluding glucose in her because she was not hyperglycemic, she was not glucosuric. So it's 2 times the urine sodium plus potassium plus the urine urea nitrogen over 2.8. If you have a lab that just measures urea, not urea nitrogen, then you divide it by 60. So the numbers can be different depending upon what you are in fact evaluating. So we have our urine osmolality, we have the urine sodium, we have the urine potassium. This will tell us the contribution of in essentially osmoles of what her urea nitrogen is going to be. And so we just do some simple math, some substitutions, and we can find out that her urine urea nitrogen is over 1200. So that is where her osmolality is coming from. And she was able to have this positive electrolyte-free water clearance because of all that urea. So urea, despite being an ineffective osmole, that is what was drawing the water out because her urine doesn't contain a lot of salt. That is how she was able to get that, that excretion of that electrolyte-free water to fix her sodium. So if we summarize that, she has a positive electrolyte-free water clearance, which is causing her sodium to go up by that little bit, But if you think about everything, it is not adequate. It should have fixed things promptly. Her sodium should be going up very quickly. And why is that not as robust? Is because of the SI-ADH that's there. If we were to give her something like tolvaptan that would antagonize the ADH receptor, you're going to see her sodium jump up. And in fact, for her, it would be too fast. So we would probably need to give her tolvaptan and then give her some D5W at the same time to prevent it from going up so quickly. So it is a positive electrolyte-free water clearance, which is why her sodium's increasing, but it's taking so long to go back to normal because she has SI-ADH in the first place. Now let's look at her sodium concentration a bit more. So we can look at her sodium clearance, and if we look at that, it falls into what the normal range is for people. We don't have a good reference range for that. We do know a little bit more about fractional excretion of sodium, and I think this is where people tend to turn to looking at urine chemistries, and this doesn't tell us anything. Looking at her fractional excretion of sodium is 0.91%. Normal is 1%. So it's actually a pretty normal fractional excretion of sodium. How is that helpful? Well, if she was volume depleted, and that was the reason for her to have this release of ADH, she should have a lower fractional excretion of sodium. She should be reabsorbing it all. And in fact, there's one paper that's come out in JVIM that looked at discriminating essentially a pre-renal, a volume responsive AKI from an intrinsic AKI, and specifically looking at fractional excretion of sodium. And a fractional excretion of sodium greater than 0.9 was the cutoff to discriminate intrinsic AKI versus volume responsive. And the performance is pretty good, sensitivity of 83%, specificity of 75, but this is consistent with her intrinsic AKI. So it tells us that she's not volume deficient, that she's not avidly reabsorbing sodium because of the RAS. That would be your Ang2 and your aldo here. This is not ADH. It's going to be your RAS that's going to change your fractional excretion of sodium. So this is where we can say her RAS system is fine. Her RAS system is not changing things. This was all ADH mediated on what was causing her change of her sodium. So this patient, you need to evaluate them for why they're having an abnormal release of ADH. You really have to look at the list in people. We have a handful, probably 10 or maybe a dozen case reports of presumptive SI-ADH in our patients. Many of them are very minimally evaluated, where you essentially have a urine that's concentrated while you have a hyponatremic patient, and that's it. That is a lame assessment of those patients, but probably to the extent of what those clinicians were comfortable managing. They're not comfortable doing these formulas to actually dig deep into it, because when we put these formulas to it, it makes sense. It actually totally tells the story of what's happening, and that spot urine told us that her sodium is going to continue to increase. And in fact, as long as her plasma sodium concentration was greater than the sum of her urine sodium plus urine potassium, her plasma sodium is going to continue to increase. It means that she's peeing out that free water. So these urine studies really helped confirm the clinical suspicion that she had AKI with SI-ADH, no obvious cause of either. She had improvement of both over time, and this was our most recent lab work panel, which shows, look at this, normal sodium 144, potassium is fine. Her BUN is now normal. Her creatinine is 1.1, which is probably not is not normal. I won't say probably. It is not normal for a dog of her size. She still is tiny, I think still under 2 kilos. And we did a urine chemistry again at this point. Her USG was think 1026 or so, but we can again see her urine osmolality is even more concentrated, which is fantastic. Her urine electrolytes are fairly reasonable, and we can go back and we can measure clearances and whatnot if we want to with these urines, but we don't have a dysnatremia to account for. So anything that we're going to be seeing now is going to be normal. So this patient resolved, and now we have a good explanation of what caused her electrolytes to be abnormal. We don't have a reason for her AKI or her SIADH, but we documented both, and that would have allowed us to treat her more effectively by knowing actually what was happening. And without those urine tests, we would have guessed maybe this could be too much ADH, but you need to confirm that by saying that she is essentially reabsorbing that free water as she's urinating. And that's not as simple as just saying her USG is high. That's an inadequate definition of it in my book. All right, that makes sense. Questions on this first case? You guys are the ones who are going to have to be doing these. I'm putting the future of urine clearance studies in your hands. It's your responsibility to get more comfortable with this because it is hard. These are things that no one does. I 1000% did not do a single urine clearance study during my residency. Not at all. I maybe started doing some fractional excretion tests at some point, and I thought I was being really smart and cool, and it did not tell me what I needed to. This is what you need to really start to become comfortable. Were you saying something, Sherry?
I was just saying I did, but because Polson made me. And it does. I know you're looking at it thinking why, but because no one else is going to do it, and it's going to make all the difference in these patients.
Okay, any questions about this first case before we go on to case number 2?
Feed just to see what's going on in her cherry gland or too small that, like, I don't know what my AKI now. I know.
Sorry,
But
Andre, your audio is really glitchy. It's hard to hear you. Right?
can you hear me?
No, it's still just
No.
cutting in and out.
Can you hear me now?
Now you're good.
Yeah.
Yep.
So since like I was just thinking, so since you found out the SIADH, even though she's like too small, would you consider right now after like when she improves from her AKI, running a CT just to investigate her pituitary gland, or this is not like in your protocol for a further investigation?
No, I think that makes a lot of sense, except for the fact that SIDH is gone. So it's not there. She's not hyponatremic anymore. She has appropriately concentrated urine. She's now pretty much resolved. So if it would be persistent, absolutely. You might look to see why. It would be very weird because if you think about most of your pituitary or hypothalamic lesions, like a tumor, are going to cause a loss of function. A tumor is going to obliterate the normal tissue and it won't work. So we commonly think about that for something like a central DI. They're not making ADHY because a tumor has obliterated the pituitary or the hypothalamus. But SIADH is very poorly understood in our patients that if it was persistent, then yes, you might think about doing some imaging to see if something could be there. Because honestly, any case that we see at this point is case report worthy because we have very few reports. Like I said, maybe a dozen or so. Many of them are not fully evaluated, and we're gonna present this and submit this to be published as a case report because none of them have these clearance studies as well too. So I think if it would have been persistent, then imaging the head, sure, would have been helpful. And for this dog that's about that big, probably MR the whole dog, just to see is there anything else that we didn't find on the ultrasound or any other lesions that could be there, since SIADH is such a poorly understood syndrome in our patients.
And it's not
Awesome.
only brain lesions that can cause it, right? So what other things can cause? So we always think of SIADH and we always go immediately to the brain, which makes sense, symptom of inappropriate ADH release. But what else can cause you to release ADH when you shouldn't be? So it's releasing ADH at an inappropriate time, and there's a whole bunch of things that cause that. And so those are the other things you need to go through. And in this dog, it was transient, and the majority of cases of SIADH are transient. You just need to be on top of it so you know what's transient and what's not. And so for the fact that this dog resolved, I think it makes the chances of a brain lesion much less. I've seen, I don't know about you, JD, but I've seen SIADH and meningitis cases. A couple of the stupid little fawn pugs with their achy brains. So I've seen it there. You see it with pain. If you want to cause SIADH, put an animal on a ventilator. As soon as you get the positive pressure ventilation, you will get an SIADH. So you combine that, and that's why we tend to see these animals lose free water coming out of anesthesia because of pain, because of the medication they use, and because of the ventilation. And so if you've got a surgeon that's astute and taking blood work on recovery, they all flip and panic because the sodium drops. And I tell them to close their eyes and look tomorrow, and it'll be fine. Manage the pain and things like that. But I don't know. I'm not trying to pick on surgeons. I love them, but
No, but you're right. Things like pain and nausea are on the list of things that increase ADH risk in people. And if you think about our patients that are hospitalized, they very often can have that. It's kind of surprising that we don't see as much hyponatremia as we maybe should for the amount of pain and nausea that we have patients who are hospitalized for. And I think the other thing is that when looking at this patient's sodium handling, fractional excretion of sodium, it also allowed you to say that it wasn't volume. And so that makes you feel even more comfortable, which maybe is harder to do in patients on a ventilator or hospitalized, looking at, are we keeping up with their ins and outs? Are they appropriately managed? Do they maybe have a non-osmotic release of ADH? And that's what the sodium is handling. Urine sodium is going to be the RAS, is going to be what's left behind from ADH. But the free water clearances, that's what we really want to look at. All right, well, let's go on to this second case so we can get through it in this time. So this was a case I consulted on it, so I can't provide a lot of the details, but this is a 2-year-old female spayed pug who has acute kidney injury due to ureteral ligation, and she's hospitalized. She's in the hospital still 2 weeks after she had a nephrectomy for her ureteral ligation. She's on IV fluids. I was told that the fluid was LRS, and she's had this horrible post-obstructive diuresis that they can't wean her fluids, and her urine output has ranged between 4 to 10 mils per kg per hour. So they reached out to me with some questions on, what do you think we can do? How can we get this dog out of the hospital? We try cutting the fluids down, and she becomes more azotemic. We can't get her out. So I said, do a urine chemistry. Let's take a look at stuff. So we have not all information. So again, I gave you guys what I had. We don't have a urine osmolality, so they didn't measure that. We did have a urine specific gravity. I think it was 1011. So I went back to slide number 1. I put the USG in to give us our formula for what the urine osm would be. So it's going to be a urine osm of about 400, plus or minus a little bit. Not okay. It should have been measured. We should have had a measure osmolality to be the most accurate as we could, but let's take a presumptive urine osm of 400. In terms of her plasma osmolality, they didn't tell me what her BUN is. Now we know, because her plasma sodium concentration is 145, her plasma osmolality has to be greater than 290. But I don't know, is her BUN 50? Is it 100? I don't know. But we're going to make some estimates here. We do have some information about some urine outputs, and they said that she was often producing about a liter of urine a day. So we'll just go with that. And even if we didn't have that number, I probably would still just put in a liter, because it just makes sense to say for every liter of urine that's made, here's what's happened. Doesn't matter if they only made 250 mils, that same proportion will be there. So let's take a look at her free water clearance. And I just estimated an osm of 400 for her urine, 300 for her plasma, and her free water clearance is negative 0.33 liters. So negative free water clearance. So if we flip that and look at her free water reabsorption, it's 0.33 liters of reabsorbed water. So let's graph that. So we have our 1 liter of urine with an osm of 400. Her plasma osmolality is 300. So that means we calculated her free water excretion, and that's 0.3 liters. So every time she makes a liter of urine, she is reabsorbing 0.3 liters of water. So is this abnormal? Is water normally reabsorbed as it goes through the nephron? And the answer is yeah, absolutely. We have ADH that's released under basal states. So this is actually pretty normal. If you think about it, if she didn't reabsorb any water, that she would just be dumping out this isoosmotic urine. But normal scenario would be to actually reabsorb some of that free water that's there. If we go back, this patient has a normal serum sodium concentration and therefore a normal effective osmolality. So they don't have a stimulus for ADH to be 0, and they don't have a stimulus for ADH to be high. So there is some free water reabsorption, which is the normal scenario as urine's going through the collecting tubules for ADH to pull some out. So that's actually okay. That's actually pretty normal. Let's take a look at the electrolyte-free water reabsorption and water clearance. Remember, this is a little bit more specific for changes in the serum sodium concentration. And we plug that in, and for every liter of urine she makes, she's reabsorbing 0.17 liters of electrolyte-free water. And if we flip that around, we do it the opposite, we're going to essentially get the same, that should come out to be about the same. So about 0.1 liters that free water that is being reabsorbed. And if we plot that again, we have our 1 liter of urine with a sodium of 150, a potassium of 19. We are reabsorbing 0.17 liters of water, and the rest is going to be isonatrate. So is this abnormal? And no, it's normal. It's absolutely okay to reabsorb a small amount of water. That's how we make urine concentrated. Remember, that's how we get urine to be concentrated, is by the removal, the clearance, the reabsorption of water. So this dog does not really seem to have a problem with osmolality and ADH. So looking at that one paper that we also looked at, the paper that talks specifically about PUPD, they cite the potential list for PUPD for a transient nephrogenic DI, and it includes an obstructive uropathy. So is this patient PUPD because they have diabetes insipidus? Is this patient having this post-obstructive diuresis from this transient nephrogenic DI because of the obstruction? And the answer is no, because we looked at this. If they had diabetes insipidus, if they would not be able to reabsorb that electrolyte-free water, they would be dumping it out. The urine would be extra dilute. And our formulas disprove that. So not only does it just not make sense totally, and I'll get to that in one moment, but our math has shown no, this dog does not have nephrogenic DI. It's actually reabsorbing free water. The other thing to think about is, can it have an obstructive uropathy when they did a nephrectomy? The kidney is gone, right? So if you have no kidney, you cannot have an obstructive uropathy. So if you have a unilateral obstruction, the animal models will say unilateral obstruction tying off a single ureter will not produce post-obstructive diuresis because the other kidney is there. Now, whether or not that happens in cats is a little bit harder to say, because I think a lot of those cats might also have a partial obstruction on the other side when they have a complete on the first. But animal models will say it needs to be bilateral to have that post-obstructive diuresis. Unilateral won't work. In this case, they removed it, but the patient still has a creatinine of 3. So what I don't know is, was this also tied off and it did have some transient obstruction? I don't know the reason for the remaining kidney to have the AKI.
That was going to be my question, is was it both kidneys that were ligated or just one? And they had
I
one was
don't know.
to remove it.
Yeah,
Well,
that's a great question,
yeah.
and I don't
Regardless,
know
something's wrong if the creatinine's 3, so.
exactly. That other kidney was hit somehow.
Yeah.
But, and so even if it was tied off, our clearance studies just disproved this patient had DI, but they gave it DDAVP, and they saw that the urine output went down.
Yeah.
Well, oh, sure, that's fine. It will, because this dog has a normal ADH axis. So if you give it super physiologic ADH, it will respond to it. So yes, it's going to reduce its urine output, but it's going to do it at the expense of that inappropriate free water reabsorption, and then we're going to have hyponatremia as a result. So that would be a very bad thing to do, but they did it for a couple days. It also would not respond if you had nephrogenic DI. You already have ADH. If you give more with DDAVP, that's not going to cause an effect. So it wouldn't even help in terms of this mechanism as well, too. So we don't, as far as we know, the obstructed kidney is gone. What's causing the AKI here, we don't know. But we can't have that nephrogenic, we can't have that obstructive uropathy if there's not an obstruction. So let's take a closer look. So from an ADH axis, it seems normal. If we look at its sodium clearance, the sodium clearance seems certainly a bit higher than our last patient, from 2.2 liters to 1 liter. Let's take a look at the fractional excretion of sodium. Is this patient behind? Is it reabsorbing too much? And this patient has a fractional excretion of sodium of 11%. 11%. It should be 1%. It's 10 times higher than what it should be. It is dumping out all of this salt. And what's going to follow is going to be water. So here's where we have our obligatory polyuria. So let's go back to that figure from the manuscript looking at PUPD, looking at urine output. And again, they're looking at some 24-hour things like 3 liters a day is abnormal. We don't have those numbers, doesn't matter. Let's look at the urine osms. So a water diuresis with DI. We already know it doesn't have it because its urine was concentrated at 10, 11, and its urine osm would probably be about 400. So it likely doesn't have that. A mixed diuresis, this is where we see the relief of urinary obstruction. It still should have a urine osm that is lower than what we currently have. Our calculated osm is 400, so it's going to put us into this area. This dog is having a solute diuresis. So is it hyperglycemic? No, it's normal. That would have been an easy thing. Is it azotemic? Yeah, it's azotemic, so it's going to have urea as a solute that's going to be driving things. Does it have an exogenous solute load? You better believe it. Absolutely. So this dog is PUPD because of its AKI, and it's having solute diuresis, like all of our AKIs will have that are not anuric. They're going to be polyuric. But it also has this iatrogenic solute load. And in that article that we read about solute diuresis, it says that it can occur from IV fluids and metabolic processes like azotemia. So let's take a closer look. So Hallie, her PUPD is likely caused by that azotemia and the sodium administration. Diving into that a bit deeper, if they match her ins and outs with LRS at 10 mils an hour, they gave her 312 millimoles of sodium per day. On a maintenance diet, she would get less than 14 millimoles a day. So by matching her ins and outs with LRS, they are giving her 22 times the amount of salt that she needs in a day. Where's that going to go? She's going to pee it out. So this is the classic case of a patient who maybe had post-obstructive diuresis, maybe they just had polyuric AKI. You give an isotonic fluid to match the output, and then that takes over, and that keeps driving it all the way to forever. This dog's never going to leave the hospital as long as they keep doing this.
And all of you should be having PTSD flashbacks to leptospirosis cases that you've managed.
Absolutely.
Or that the ECC people come to talk to you and they're like, yeah, about this. And then you have to sit down and go through a fluid plan with them. So this is, I can't tell you how common this is. I mean, the post-obstructive diuresis, I'll give her that. But the driving the polyuria and being the reason that we can't get them off of fluids. So you got to be a little cruel to be kind, and you need to make sure you're using the right fluid.
Absolutely. But what about her partial response to ADH? Well, her ADH axis is intact. It's fine. She doesn't need ADH. She probably has somewhat low ADH release because of all the water and salt she's being bombarded with. It's isotonic, so her osmolality is preserved. Her volume is normal, if not high. So she doesn't need to make much ADH. If you give her ADH, that will reduce the amount of water that's there, but at the expense of causing hyponatremia, which they didn't specifically look for. And then what about the fact that every time they try tapering her IV fluids, her creatinine increases? Well, you're diluting it out less. If you're giving her so much fluids that you're driving this, you're also just diluting everything. So when you start taking it back, it's not surprising that you're going to see the creatinine go up. But that doesn't mean to give more fluids. It means you're just diluting things less. And this patient, you would have to be somewhat cautious about dropping the fluids slow because they are dumping out a ton of salt. But you just need, as Sherry said, like you need to be a little bit cruel and say, well, yes, you will be more azotemic, but that's actually a better representation of the kidney function than when you're flooding them with so much fluids you're diluting. So don't let that rise in creatinine tell you that you're moving the wrong direction. Look at your patient's weight, their overall clinical status. Are they still BAR? Are they eating? Are they generally feeling well? Even allow them to get a little bit behind on fluids so that you can really cause them to reset themselves and decrease their urine output as a consequence. But if you keep matching ins and outs, you will never stop. It will continue forever. But you just need to turn the pump down, if not just stop the fluids. You probably could have stopped the fluids on day 3. On day 14 of management, you got to turn the pump down. You probably can't stop a cold turkey because that patient's going to be peeing out way more salt than what you're going to be giving it dietarily wise. So it's going to have a negative balance and it will become dry. So I probably do about a 25% reduction, let it hang there for a day, maybe another 25% reduction. And ultimately, try to get this dog out of the hospital. Do that fluid reduction at home with an E-tube in place rather than doing it all in the hospital. So this is a classic case of PUPD that's being driven by the iatrogenic salt administration in this patient. And I was not surprised just hearing about the case, but actually doing the math and looking at everything, we have all this information that actually excludes the things that they were throwing out. Nope, it's not that. Nope, it's not that. And we have a better handle of what's happening. So these urine chemistries, these urine clearance studies are awesome. They're really powerful. They are confusing. I will tell you, you'll probably have to read these articles every time you do one of these studies, and that's okay. If you're not doing it routinely, it's almost like, and for me, I have to relearn it every time I do it, but they are so helpful. And I would encourage you to measure urine chems with a urine osm. Make sure you get your creatinine urea on there as well too, and use it when we're evaluating our cases of PUPD, our cases of dysnatremias, especially for those patients that are hospitalized. It will help you tremendously. So I hope that was illustrative of the power of these very confusing formulas.
But very fun too.
They
Yeah.
are.
I
They
mean,
are fun.
yeah,
It's amazing to go through those cases and be like, yeah, it makes sense. It does. And you are by far the smartest person in the room
yeah, it's good for your self-esteem to do these equations.
because no one else is going to even try to look at it because they can't even explain what free water clearance and electrolyte free water clearance is. And maybe tomorrow you might not either, but you'll have a better chance of remembering it when you go through it again and again.
That was terrific, JD. Thank you.
Yeah, of course. Any questions on those two cases or using the formulas?
Yeah,
I
when
think
I
our
was doing
first
the
case,
exercise, sorry,
no, go ahead,
what you were
Andre.
saying?
Go ahead.
No, when I was doing the exercise on the same paper, the polyuria paper, they also mentioned another formula for finding the solute diuresis for the estimate in 24 hours. So
Yeah.
I applied for Haley's, and her solute diuresis was like beyond the reference level, and I was like, yeah, she's actually like excreting a lot of solutes for sure.
Right, right. And
Yeah.
it has to come from somewhere, and it comes
Yeah.
from what's going into her cephalic vein.
Thank
I
you.
think the important parts are, remember, it's a snapshot. And I think our first case, Coco, would have looked different on day 1 and on day 3. We would probably not have seen that paradox between the free water clearance and the electrolyte free water clearance. Both would have gone in the same direction to establish the hyponatremia. And the fact that she had that electrolyte free water clearance that was positive, that allowed her sodium to come up, was going along with her resolving AKI. So her kidneys were starting to function a bit better during that time, and she was starting to be able to have a more appropriate response. So this is something that you might not just have an answer by doing it once. You remember, that's a snapshot. It's going to tell you about where things are in relation to time. Looking at it again could be helpful. But even a spot check, getting a urine sodium and potassium and comparing it to a serum sodium concentration, those 3 numbers will tell you what's going to happen to your patient's sodium, plasma sodium concentration in the next 12 hours. So if you have a hyponatremic patient and you need to figure out, do I need to add, give them hypertonic saline? What do I need to do? Checking those 3 things, which might be able to be done in-house very quickly, will tell you if you can just sit tight because it's going to go up because the math and the physiology is doing it, or is it not going to change and you have to intervene with some type of food. So these formulas are powerful. Even more powerful is when we understand them, the renal physiology that we can master and use in our tools of assessing and managing patients is phenomenal. So I hope these exercises were helpful. Hopefully you guys will be able to come back to this and use it in future patients as well too, because it is really illustrative of the power of the kidneys.
This is just another fun anecdote. We used these. We had a cat, and the owner was insistent. I mean, we knew that the cat was getting a solute load from somewhere, and it wasn't diet. It was an E-tube cat, so it certainly wasn't coming from diet because the cat wasn't eating on its own, but it sure was drinking. And we used all this, and finally, I mean, after lots and lots and lots of going through everything. The cat, they had one of those Himalayan salt lamps. The cat had eaten the whole back off the lamp. And that's where the solute load was coming from. But it was only because I kept, I mean, they would have found it eventually, I'm sure, but it was only
Right.
because we kept seeing there's salt coming from somewhere. And you know, you've got to figure out where.
Yeah,
So
and
yeah,
that's like a
that was
Sherlock
a great
Holmes
case.
moment right there. That's awesome.
That was a great case. That was a fun one. So
All right, well, thank you, everybody. Really appreciate you coming in. I will throw this recording up on the website, and we'll get some articles together for next month. Hope everybody is doing well. Look forward to seeing you guys again soon. Take care.
yeah, I'm excited I can finally join. No labs. So
Always
you.
like to have you on, Sherry. Absolutely.
Thank you. Bye bye.